some people. So I'm Steve. I'm one of the ICU consultants, and this is the perioperative medicine sort of lab group, isn't it, that I'm talking to? Yep.
Yeah, that's right.
So we run a similar sort of group, quite quantitative, but sort of more based in critical care. And I gave this talk to them, and we just sort of talked through a little bit like what the process of getting the grants was like. And so this grant application is called HYLODE. I don't really know what that's supposed to sound like when you say it out loud, but it's meant to mean a hyperlocal bed demand forecast, and I'll explain that in a little bit more detail as we go forwards. So as you well know, our current government, even with its recent departures, is obsessed with technology and thinks it's going to fix and save the world. And while we don't believe them and we think they're massively naive and over-optimistic, they are offering a lot of money for anything techie at the moment. And so they've done another bit of standard political rebranding of everything and created something called NHSX, which I'm sure you've probably heard of by now. The big thing to know about NHSX is they got given about 140 million quid to basically do AI projects in healthcare at the beginning of the year. And they're burning through that money quite fast, and they put out a grant call at the end of January, inviting people to apply. If you go and look on their website about the definition of AI, so this is basically AI in health and care, you'll be pleased to discover that you could basically take your linear regression model and call it an artificial intelligence platform. That's on an official NIHR website. Quite clearly, you don't necessarily want to tell them that, so you need to dress it up a little bit, but the bar isn't too high. So there you go. So this came out, and we've been in our lab running on a grant from the hospital charity and a couple of fellowships and a couple of PhD grants recently. And we thought that this was probably a pretty good bet for the sort of stuff that we were doing, so we decided to have a go for it. So it wasn't too arduous either. They put out some webinars. There was a thing called a pre-submission engagement form, which you'll be delighted to know again for the AI call was essentially a Google form you had to fill out. And obviously so many people went for it, they couldn't even get through all their pre-submission engagement forms. They eventually closed that off before the thing died. And then they asked you to select your application. And the one thing which is really different to this grant to anything that I've done before is it was really, it's really around product development rather than a sort of an academic project or a fellowship. And so they had this sort of split up into phases. Phases 4 and 5 were basically things which are already products, so you were trying to sort of distribute across the NHS. Phase 1 was basically if you had an idea on the back of an envelope which sounded like AI, and they give you up to 75 grand in about a year to play with that money and do something with it. So kind of, you know, you didn't have to have anything in production. Phase 3 was if you've got something and now you need to generate evidence to show that it actually worked. And phase 2, which is what we went for, was basically if you've got an idea, you've already got it working in some form, but you now need to sort of build it up to an actual functioning prototype that you could take on to deploy. So we went for that one. There was no limit on the amount of money that you could apply for. And I think they kind of wanted the work done over a couple of years. So one of my co-investigators says make that 26 months because I'll never notice the difference. You can apply for some extra money. So we did the expression of interest. That wasn't too bad. You had to write a plain English summary. You had to do draft costing. Has anybody done costings at UCL, NHS? They're a right pain. And so even for a draft costing at UCL, it's worth knowing that you have to complete a work tribe application and fill it all out and get all your salaries and decide what band everybody's going to be on and so on. And so just budget some time for these things. I suspect you've got some very knowledgeable administrator in your departments, and they are worth their weight in gold because they understand how all these things work. They understand the timelines. They know how to get these forms submitted and completed. And the good ones are also quite pragmatic and don't make you sort of jump through multiple hoops. They just say, pick a number and write it in here and we'll deal with it later. You're recording this, aren't you? So I'm going to be in trouble. Okay, so we did plain English summary, draft costing, project plan. Like I said, this was sort of based off this I4I template, which is basically around project development or product development, and some team details. You'll notice that the dates for all this worryingly overlap with Surge 1 and the COVID crisis. But we kind of got the expression of interest in kind of as things were just kicking off. We got panel feedback basically around about peak surge, and then we had just enough time after we came out of the surge to get on and do the next bit. Oh yeah, I was just going to sort of show you. So costings, like I said, you've got to speak to UCLH JRO. The signatures wasn't too bad for this, but that's another massive hold up for these things. Is really early on when you're doing one of these grants, go right to the end of it, work out whose signatures you need, work out whose CVs you need. In this particular one, my disaster was it turned out that I gathered everybody's CVs, but it turned out that everybody actually had to individually register on the grant application system and upload their own CVs, and I couldn't get the thing signed off in the last 30 seconds of the deadline without a huge amount of panic. So maybe go right to the end of the thing and work out how all these things go through. You've got to make some pretty picture, one of these waterfall diagrams, Gantt charts to show how it will all go through. So we made one of those. And then we got some feedback. Feedback came on the 15th of April, like I said, around about peak surge. And they said the application is timely because by then there's a current pandemic, and we were talking about trying to manage bed forecasting, better bed allocation inside the NHS. We said we had a good plan, but not enough description about how the input for the algorithms can be obtained. They wanted further explanation of how the technology will be deployed across the NHS. That comes quite important later on. And then they wanted some confirmation around right to access the data and what we would do with it. So the deadline for the stage 2 was then 20th of May. So like I said, as we came out of the surge, when we had a bit of downtime from clinical work, I ended up doing quite a lot of writing. By the 10th of June, we then got peer review on the stage 2 written application. We had to do some more comments for that. The 24th of June, we then expected to do an online presentation. We've obviously been in face-to-face pre-COVID times. And then in fact, they said that we'll get the panel outcomes around about the 6th of July. In fact, that took us through to the 17th of August before we heard anything back. They then gave us a 2-week turnaround for some further feedback. I said I was going to be camping in a field in Wales and they were going to have to wait a bit longer, and they were all right about that. There was a press embargo around the announcement, and then they formally announced the whole project around about the 8th of September. And for anybody who'd like to repeat this entire process, their next round has just opened in the last few weeks. So if you've got a techie idea, think about applying. Alongside the stage 2 application form, you needed letters of support. Well, you don't need letters of support, but I think this is just good grantsmanship. Find as many important people as you possibly can. Write a letter from them to you saying what a wonderful person you are and what a great idea this is and how it's going to change the world, and then ask them if they'd be kind enough to sign it. You've got a finance form to do. That requires you finding the right person in the JRO who again understands how to fill these things out and will assign the right salary layers to this. And you have to make a decision if you're applying through the university, if you're applying through the hospital. So this one we applied through the hospital with the university as a partner. You've got to do a thing called the schedule of events cost attribution template, but actually you don't. It's not too bad. It looks like a massive, awful Excel spreadsheet, and it's basically saying how much will this project cost the NHS to deliver if it's going to be deployed inside the NHS. Because this is sort of a techie thing, then we could pretty much say we weren't actually going to be speaking to any patients or using research nurses or anything else like that. The PPI plan and PPI budget, that was another Achilles heel for this one. We got a huge amount of grief from the PPI people on the panel that we hadn't done enough PPI. We took the view that we were building a product, which I'll show you in a second, that was for staff. So we're trying to build a bed forecasting tool for staff to use. And so we sort of said, look, it's the staff who we've done all the research with. We've got all this sort of user interviews and user research we're going to do with the staff. It doesn't make sense for us to do that with the patients, but they didn't like that argument. And in fact, they came back to us when we were awarded the grant, or kind of around the stage 2 thing. They said you can have the grant, but you have to come up with a decent response and do some better PPI. So we had to write a whole new work package for that. But they were flexible when we said if you want more PPI, it's going to cost more money. They allowed us to add some money to the budget. Gantt charts, CVs and references, all the usual stuff. I saw, and I was involved with a grant with Ramley's group at the same time, which had a beautiful little Gantt chart. So I copied their layout design and did something very similar to that because I thought it looked very pretty. And then we submitted this and just tried to describe what went on. We've split the thing into these work packages, which again seems to be a standard part of how you describe grants. So there's a sort of a governance and setup piece. There's a piece around application foundation, and we tried. I found this bit of the grant writing really useful. In trying to write the grant, it really forced me, and this is why these things are actually quite hard. It was like trying to sort of write what you're going to do over the next 2 and a bit years, month by month, and really trying to work it out. So although you kind of write your Gantt chart after you've written all the things you're going to do, it did force me to kind of think, how are we actually going to deliver this bed forecasting product that we're trying to build? What will we do this? And so, you know, we came up with what we think is actually a deliverable plan, which kind of involves taking the smallest possible and the simplest possible steps right at the beginning with as few external dependencies as possible. And so really, there is an existing product, which I'll show you in a second, that works for this, and it's all written in an Excel spreadsheet with some fancy Visual Basic code in the background. So the application foundation for this is we're just going to build this very simple web app. It's not going to be live, it's not going to do any data integration, it's not going to do any AI whatsoever, but it's just essentially going to look like your sort of a digital version of your ward whiteboard, or really just if you like a Google sheet or an Excel sheet, but just an online thing where the users can interact with it. They can write in the patients who are currently on the ward, they can put their expected date of discharge, and they can keep it updated and that sort of stuff. The idea for this was that if we did it that way round, we would put something into users' hands right at the beginning. And we've got a healthcare designer who's going to work with us on the project all the way through. And it just means that she can always have a product that she's working with and she's giving to the users. And the users can always say, well, actually, I don't like this, or I need that. And we can always try and then sort of work around the things that they want to make sure as best as we can that we're building something which is going to be useful for them. So that's the foundation bit. Integration means we now start trying to actually make the thing connect and talk to various parts of the hospital, so people don't have to hand enter the stuff. Work package 4 is around trying to upgrade the AI component of the model. Work package 5 just kind of describes that user design, user interface work that we do all the way through. Work package 6 was around trying to generate outputs and products to show that the thing might actually have commercial value or investment value, I guess, in the future. So we need to be able to, we're not going to show in this one, we're going to save lives or reduce length of stay or anything else like this. What we hope in this grant is to show that we can build a product that people use. So, you know, if we can sort of show that people are logging on, that it's got lots of clicks on it each day, that it's accurate, that the forecasts look like they're roughly saying the things that you would expect, and it's become through maybe some qualitative sort of reporting and so on, an important part of people's workflow in the day, and that will allow us hopefully to build a good case for taking this forward for further funding. And then the last piece was the quality management piece. And so again, because this is meant to actually be around product building, then I had to go and get some help, and I had to read a lot of incredibly incomprehensible documents, all starting with the words ISO and ending with 5-digit numbers, to try and understand how you actually take a piece of software or a code or a model that you write, and that you're allowed to actually run it in the NHS and use it for management. We're not building, and this is good, but it doesn't make it completely easy. We're not building a medical device, which would make things even harder. Medical devices where you're actually going to report on a sort of a patient's current status, and it might trigger some clinical intervention, require a different set of regulation. But we are nonetheless deploying software inside the NHS, which might have effect of people's outcomes. So we got, just before the panel presentation, we got some written feedback from our peer reviewers, and so again that helped us sort of design the presentation and try and answer some of the criticisms that come for that. But again, was another piece of work to try and deliver and get those back on the appropriate timelines. And then this is the little presentation, which I think will hopefully make a little bit, or hopefully make some sense of some of the things I've said so far that we gave to the panel. You will notice, and you will know about never make the same mistake. I've got far too many slides for a 10-minute presentation. I'll try and deliver it to you probably in just a bit over 10 minutes, so I don't have to speed talk all the way through. But I can tell you I did actually manage to get it just in time. Okay, so I split it up into 3 parts: opportunity, proposal, risks, mitigations, and comments for the future, which is really that peer review feedback piece. The grant's basically got 5 investigators on it. So me is the lead, a team from UCL's Clinical Operation Research Unit. That's a chap called Martin Utley and Sonia Crow, who some of you may have met or know. Ken, who's from the Institute of Health Informatics and is sort of our AI guru and looks after work package 4. And then Jonathan is a software engineer at UCL's Research Software Engineering Department, and we've always worked with them on our sort of software projects. So I had to make the case around why this was important. This is stuff which you guys will know and probably be sick to the back teeth of hearing. But you know, Ramani and Danny's work clearly shows that there are lots of cancelled operations, and we all know that our provision of critical care in this country, it may be changing at the moment, but has traditionally been right at the bottom of any sort of comparative ranking. I got this beautiful graphic drawn a couple of years ago when I started my Health Foundation grant, and I had to do a sort of a day's event for the Health Foundation and the hospital. If you ever get a chance, this thing has turned out to be so useful because I get to keep using it. They have these people called graphic scribes or visual scribes. Have you seen this? They essentially come, they join your meeting for the day, or they join anything you're going to do for the day, and they walk around, they just draw pictures, and then at the end of it they send you the picture, and they're really good. So this lady, I don't remember her name, basically came and tried to look at the whole sort of daily bed management process. And so she showed up at the hospital at 7 in the morning with, you know, a fabric bag full of marker pens and a massive roll of paper, and then she walks around. She's just kind of, we walked up to pre-assess surgical reception, we walked to theatres, we went into theatres, we walked onto the ICU, went to the bed management meetings, we went down to the operations centre, and we spoke to different sorts of people. And she doesn't do any drawing at that sort of stage, she's just sort of listening. And in the afternoon we had these sorts of meetings. In the meetings we kind of got people together and so on. She then kind of drew what's sort of going on. Anyway, the pictures are beautiful. They're really clever, and they're a really great way of then communicating these things. And if you've got to sort of tick PPI boxes and all that sort of stuff, and you want to try and explain to people what you're doing, I couldn't recommend the whole process more highly. They're really clever people. They're really good. During that process, then the theatre we went into was actually Catherine Jenkins' theatre, and the graphic scribe lady, she asked Catherine what the morning was like, and Catherine said it's a flurry of awfulness trying to get theatre started and things up and running, which I've then basically stolen Catherine's quote and used it in all sorts of things going forwards. But the whole point really, isn't it, and the whole point of this little slide bit was that I just made it absurd. I mean, you know, it is stupid, isn't it? Even now with our fully digital hospital, do you think any of this stuff has changed? Well, you guys know it hasn't, has it? You know, we still do surgical booking and pre-assessments in days and weeks before, which means we do have notice of what's coming towards us. The theatre scheduling meeting is still 3 o'clock the afternoon beforehand. The patient's still arriving at 7 AM and we still don't know if we've got beds or what can go ahead. And then we're still doing some sort of crazy surgical PACU bed allocation. In fact, the thing I've literally just finished before I joined your meeting here was doing our daily ICU sit rep at 9 AM on the day of surgery. It is stupid, isn't it? I mean, like, you know, you can get your Ocado shopping delivered to 1 hour time slot. You can send a parcel or a letter across the world, have it picked up from your house and delivered to someone else on a time schedule. And yet we're in a hospital with a turnover of something close to £1 billion. And yeah, this is the way we manage our most important resource. And it goes wrong all the time. It's miserable for patients. So I think I can make that case really well. And I got some pretty pictures, and that's where a lot of my slides came from. So the cool thing is that there are clever people like Martin and Sonia who've had a go at fixing this sort of stuff. And they've done this a really long time ago. And they've done this in that incredibly pragmatic way that you do if you're not going to be too optimistic about tech and the NHS. And they basically went and they did all the right things. They worked at Great Ormond Street's cardiothoracic ICU for a good few months. They called the program a sort of a modeler in residence program, so mathematical model, obviously. And they did the same as the graphic scribe. They sort of watched and they wandered around to see what was going on. They built a simple-ish sort of classification regression tree to predict length of stay for patients on the ICU. And for patients coming towards the ICU. And then they wrote an Excel spreadsheet and they did their own little bit of graphic design and user research and so on to work out what's going on. And taking just sort of two inputs, so knowing the patients that were being booked for surgery, and because Great Ormond Street does all this crazy congenital corrective cardiothoracic surgery, they have patients coming from all over the country. So a really nice story about basically trying to say to the poor family up in Glasgow with some sick kid with some odd heart, don't come down today because the ICU is going to be overfull and we will have to cancel the operation. It makes it sort of powerful. So they took the bookings and they didn't need to know actually a ton about the bookings to understand what the length of stay for those patients are going to be. They knew a bit about the emergency ones. It was really just kind of like, is the kid above or below the age of a year? Is the kid going to require bypass or not? And once they went through theatre, was there a major complication in surgery? And that was kind of enough to give them a pretty informative view of what the predicted length of stay was. They then do the bit below at the bottom left, which I'll let someone else volunteer to read out loud, but what they call hard sums. And they made the little cell at the bottom, which is just a sort of conditionally formatted Excel spreadsheet cell saying the probability that your 12 beds will be occupied or your 13 beds will be occupied or otherwise, and they color code it. And then so basically every morning the bed manager for the cardiac ICU for the last, well, up until Epic arrived, comes in, types in the updates to the Excel spreadsheet. They've only got 21 beds, so there's not that much turnover. It doesn't take them that long. There's a big blue button on the spreadsheet which they push, and that happens. The Excel spreadsheet goes into overdrive. Your computer gets very hot. It does a lot of hard sums, and it makes the forecast, and it shows what your bed demand for the next week looks like. So in terms of the AI grant process, then we were clearly already had a product. We already had something which sort of worked, but there was a whole set of reasons why it wasn't going to be scalable as a prototype that we were able to cite. And so basically it's in an Excel spreadsheet. It's tuned just for one hospital's cardiothoracic ICU. It's completely dependent on hand data entry. And the maths essentially means your Excel spreadsheet will literally explode if you try and go to 24 beds or something else like that, because it just gets too hard. So we said we've got a product, but we need to make it better. The second bit is that we said we've got a platform, as in we could actually do this at UCLH. So when I went for my Health Foundation grant about 3 years ago, I had a similar sort of techie idea, and the criticism they leveled me at that, and again, it's a great quote and I use it all the time, was they said they don't like funding tech projects in NHS because they never work. And so what we've actually been doing at UCH for the last 2 or 3 years, and you'd be very welcome to come and start using because it does now work, is we've been trying to answer that criticism that outside people see that you can't do tech development inside the NHS. And so we've built this thing called EMAP, which basically means that we can do data science against live data inside UCLH and build products and analytical models and actually software applications as well. And so just to sort of prove, I don't suppose all of you absolutely love the command line, but Enoch, whose name you can see at the bottom right, was one of Martin's postdocs, and he basically took that forecasting model, the hard sums bit, and updated it with a new little clever thing, which basically looked at the patient's journey as you move through the hospital. So kind of if you go through A&E to AMU to T7 hyperacute stroke and down to ICU, then you can have a different predicted length of stay and set of outcomes to someone who comes in through surgical reception, that sort of stuff. So you're able to update and have this fancy new model for that. So he writes all of that kind of in his own laptop, doing all the maths and that sort of stuff. And then EMAP basically means that on the 8th of November, this is just last year, we were able to load that up onto EMAP. We had to do a bit of fiddling with his script to try and make it match our data sources and that sort of stuff. And within 2 weeks, we were able to build that little forecast you can see at the top right, and that's just a little heat map. Each of those numbers at the bottom is a ICU shift, so going forwards in time, shifts 1, 2, 3, and 4, and then it's just predicting how many beds you're likely to need. Now, those of you who've been paying attention are instantly going to see something which makes this forecasting mechanism quite different to the sort of forecast you normally see. So how many beds do we have on the ICU on T3? Yeah, so we've got 35, all right? And the forecast is quite clearly saying there's a probability you're going to be using 40 or 45 beds, not a hugest, biggest probability is sitting, as you can see, the darkest areas around about in the 30s. But it's still possible. So what this forecast does is it's a demand forecast. Let me just go on and explain that a little bit more. That's right. Let me just skip on for 1 sec. So we said, I'll come back to this, yeah. So we said basically the proposal, we're going to update the beds, and we're also going to look at things like side rooms and staffing as well, because you can sort of do something very simple for this. You can just split your forecasts just to work on side rooms, or you can multiply your forecast up by the number of sort of work units a particular bed will use. So you can think about staffing to go with that. Demand thing we'll come to. So we're going to update the models to learn from the networks of wards, and we're going to improve the range of predictors to work with patients across the whole hospital, so not just kind of kids on bypass or not. And then we can think about infection control status, COVID green, COVID blue pathways, staff and skill mix. So the demand piece, which I was just starting to speak to you guys about a couple of slides ago, is essentially captured by this sort of idea, is that most forecasting systems are simulations. So they essentially look at your historical data and they try and predict accurately in the future what your future bed status will be. So quite clearly, a forecast of that type can never predict that you will need more than 35 beds, because you can never actually have more than 35 patients in a 35 bedded unit. But that doesn't actually give you any sense of what the pressure on that unit is like. A demand forecast is slightly different. A demand forecast says how many people would like to use your beds, even if you couldn't actually provide them. And the key difference is that the reason you go from the demands down to the actual realization is that all of us have techniques, and every hospital has a whole bunch of adaptive strategies that it employs to try and make sure that you get the right number of patients into the right number of beds. And so that means things like cancelling patients, or putting a high-risk patient out on a normal ward, or prematurely discharging a patient from the ICU to make some sort of space. Now, if you do a non-demand forecast, then essentially you are including all those maladaptive strategies in your forecasting approach, whereas demand forecast actually will, if you like, always be inaccurate. It's going to tell you that you need more beds than you actually have, but it tells you about the pressure, and it's the pressure that we're kind of keen to be able to tell people about, because that will allow you to say to your wards, you need to flex your staffing up, or it might be able to say to your surgical pathway coordinators, you need to reshuffle your patients because you're unlikely to get the service that you're expecting. You might have a cancellation on a day, or you'll be asked to go ahead without access to critical care. So as a tiny little analogy, you can imagine that traffic's heavy and you're just trying to do some sort of Google Maps forecast for getting to work on time, and you're commuting to work at 8 AM, and the question is, will I be late? A utilization model rather than a demand model says, nope, you're going to be fine, because what you're going to do is you're going to start your commute early at 6 AM. Where a demand model is going to tell you that you're going to be late because it understands that you would normally leave your commute at 7 AM in the morning. So the former allows you to sort of, doesn't allow you to make that sort of adaptive change, the latter does. So that's the demand bit. The next bit, and this is something which has come forward and is really different to most of the quantitative modelling that I've done in the past, is that so when you load up your data and you do a model, you'll tend to end up working with kind of things which are true on average. But when you're trying to do something which is sort of delivered as a service or an application, then individual errors, or whether the patient's in a room, or whether a particular patient's age is right, or whether or not they've been discharged already, or whether or not their surgery has been changed, are in front of your end users the entire time. And so anything which is like that then looks glaringly wrong at the level of the individual, because people kind of know the patients on their ward. And it means that when you're trying to build a sort of data pipeline, you have to go from something which is, you do your standard checks to make sure that you've got nobody over the age of 120, or no neonates and adult ward on onto the ICU. But you kind of, well, there'll be some softness around the edges of all those checks and most of your data analysis pipelines, as you're not going to investigate in a data set of whatever 10,000 patients every single bit of missing data or slight deviation from those things. But when you're taking those data and you're giving it back to users, if the data is not 100% accurate, then users lose trust in the system and just feel the whole thing isn't working particularly well. So the solution to that, if you want to move beyond the bits of whiteboard and plastic paper that we stuck on the walls during COVID, is really taking that idea that you're allowed to interact with your data And so the whole point of the design process that we try to put into this is that we're actually building an application that from the outset, if you like, we'll do our best to make sure the data is accurate, but allows the user to seamlessly, just as if they're picking up a whiteboard marker, make small corrections. And there's a massive advantage to that as well, because as soon as you allow people to interact with the data, you can start trying to capture bits of information that simply aren't going to be available through your electronic health record. So if I want to do a bed forecast, I want to predict that someone's going to have a length of stay of, say, 5 or 6 days, then my forecast is likely to be true on average, but it's almost certain that there's going to be a whole series of edge cases where you on the ward know that, for example, that patient's got, I don't know, on some end of life pathway, they've got a dog at home and they're desperate to go home and see their dog. And we've decided that's a big deal and we want to make it possible for them. And we're going to organise their discharge and move heaven and earth to get them out a bit early. Or conversely, someone's, needs some carers, or their family's their carer and the family's away on holiday. And it's going to take them a week to get the family back to get them in, and their discharge is going to be delayed by a week. You're never going to have that information in your electronic health record or in your digital product, but we all have that information in our heads. It's all part of how we understand how we look after systems. And so a key part of what we're trying to build is to make sure that you kind of have this incredibly low threshold and low barrier to interacting with the data. And so I'm clearly not going to write a column on the board or on your web app which says, do you have a dog and are you desperate to go home? But it's very easy to have something which says expected date of discharge 3 days, and for you to look at it and go, well, that's rubbish, they're going home this afternoon, for you to correct it. And just, you are then capturing something which you simply don't want to get in any other sort of way, and hopefully makes the product much, much more useful as well as trustworthy. The next bit, we have to talk about the whole thing being transferable, because we're obviously trying to build a product so it has to work somewhere other than UCLH. So again, this is nice because it works on the same set of principles. If we say you can do manual data entry to make the thing work, then you can clearly work in a low-tech environment as well as a high-tech one. And then we obviously had to make sure we were ticking we are doing some AI type of box as well. And so there's this idea, or this sort of set of concepts called transfer learning. And transfer learning simply means is that you can essentially take, if you like, the rules of the world that you learn from one setting and apply some principles derived from those rules to another similar but distinct setting. And so what that might mean is that you might build and train your model and your bed forecasting system at UCLH, but you now want to run it at, say, Blackpool Royal Infirmary. Now, Blackpool Royal Infirmary doesn't have, 2 years worth of electronic health record data to build and make these fancy bed forecasting models, but there's going to be something similar about the patients between the two different sites. So transfer learning sort of says, look, you could probably get away and get a really good forecast at Blackpool Royal Infirmary by using the training data from UCLH to make these things work quite nicely. So that's something we've said we're going to try and do. And we're going to try and develop and test that by essentially trying to imagine a similar example that's inside UCLH. So we'll essentially build the models for the ICU, and then we'll see if the models are trainable and adaptable if we deploy them for a different ward inside the hospital. So take it down to the AMU. They clearly won't work in the same way, but there'll be some principles in them which will be important. We talked a lot about how we're going to work with the users. And so this is our current dashboard, and I'm just really here trying to pitch to the grant panel that we've built things before and they work and they look pretty, and we do talk to our staff. And then clearly I had to sort of deal with the criticisms from the peer review. So as I've said already, they were upset with our lack of attention to PPI. They brought up issues around models of trust, and I thought we could talk about that quite confidently, because actually we had this whole idea that you're going to be able to change and modify your things. And then they criticised us too for just working at UCLH, UCL. So I phoned up some friends in different hospitals and tried to say, if we got something working, then would you be able to help us out with this sort of stuff as well? Right, this is all just blah, the project, the team, and that, I think, is it. Yeah, so we've got the panel outcome. I told you about those bits and pieces. This is the thing which is basically said they were upset around the PPI and what we had to do around that. There was a whole bunch of new stuff I needed to do as well around commercialization. So there was a section on the grant, which I copy pasted from someone else's grant application, because again, that's how these things seem to normally work, around how you're going to commercialize this. And I basically wrote things like, there's a lot of patience and there's a lot of delay and a lot of cost to these things, and therefore there's an opportunity for this to be valuable to people, and they just wanted, you know, your market, your other competitors in the market who's likely to buy the products in the future. Have you approached them? What would they want? How would it fit with their business model? What's your business model? Yeah, all sorts of stuff that I simply had never had a go at doing before. So, sorry, that is the end of the presentation, and very happy to answer any questions.